Hey, it's Dr. Jessica Shellac here. I'm a spine surgeon with Texas Back Institute, and this is hopefully the first in a series of videos that I intend to make for my patients undergoing surgical procedures. The point of these videos will be to educate you on your upcoming surgery so that hopefully this can answer a lot of the questions that you have before you have your scheduled preoperative visit with me. Today's video is going to be discussing a lumbar decompression surgery. We use the term decompression to mean removing pressure on the spinal nerves. And the reason for this surgery is generally because the spinal nerves are being pinched in the spinal canal. That may be a combination of soft tissue, bone, or often both. The technical term is a laminectomy. The bones that make up the back part of the spinal canal are called lamina. And so some portion of these bones needs to be removed in order to unroof or decompress the spinal canal. So what happens intraoperatively is that an X-ray machine allows me to localize the surgical level or levels that need to be addressed. I'll make a skin incision overlying those levels, and the size of the incision will be as small as I can possibly make it in order to get down to that level. Clearly, if it's a multi-level surgery, it's going to be a larger incision than if it's a single-level surgery. Once I get down and verify that I'm at the appropriate surgical level, the muscles that insert onto the bones have to be gently elevated off. It's not cutting or destroying the muscle, it's lifting it off the bone, and that allows me to get to this visualized space here, which is basically my entry into the spinal canal. Now there's ligament tissues, things that aren't represented on this model. I do have to remove some of those ligaments in order to get into the spinal canal. I'll take a little bit of bone from the lamina, which is where the terminology of a partial or complete laminectomy comes into play. I'll always take the least amount of bone that I need to in order to decompress the nerves that are being pinched. Once I'm able to remove the bone and the ligament tissue, the nerve sac, which is basically like a fluid-filled balloon, can then re-expand. And that's, in essence, the goal of the surgery, is to remove structures that are pushing in from behind to allow the compressed nerve to have room again. Now, there's obviously risks with any surgery, and the biggest things to keep in mind that are specific to a spine surgery or a decompression surgery like this is that the nerve sac itself, it contains spinal fluid and the spinal nerves. The lining thins out as we get older, and in the scenario of substantial spinal compression, especially if it's been long-standing, many times that lining can stick down to the surrounding bone and ligament tissue. It's my job, in order to open the space up, to separate those structures. But if they're stuck down, you can imagine that makes it more challenging to separate them. If I'm not able to separate them well, that could lead to something called a spinal leak, where there may be a small hole or a tear in that lining. Spinal fluid would then leak out, and I would have to do a repair in order to make sure I can get it to seal. The chances of a spinal leak in general are not very high. They're much higher in the setting of severe stenosis, where on your imaging there's no passage of spinal fluid, stenosis that's been going on for a long time, many months or years. In the setting of a slip of one vertebral bone on another that's also contributing to the stenosis, those are things that increase the likelihood of a possible spinal fluid leak. Revision surgery also means there's a higher chance because now there's scar already from a previous surgery. After doing the decompression, most often nerves are very happy and people get improvement in their symptoms. But what I'll tell you is that there's no way to absolutely predict how you're going to do from the surgery. I would not have recommended it if I didn't think you're going to improve, but just to make sure that we all understand what spine surgery can do and can't do, the goal is to help with leg pain. Oftentimes there's a component of numbness and tingling as well. This can get better with the surgery, but it's not as predictable. pain's more predictable and generally improves pretty quickly after surgery. Numbness, tingling, and even weakness, if that's present going into surgery, it's less predictable. That's not to say that it can't get better, it's just that it might not get better and it can take a long time. So I think it's important to understand that going in and realize that after a surgery like this, there can be improvement up to a year out from surgery. Nobody wants to hear that it can take that long. And truth be told, most of the improvement that you're going to see, you'll see in the first few months. But just to understand that, don't get discouraged if immediately after surgery all the pain or numbness isn't gone. That's often not how it works. We love it if that happens, but that's not the way that it typically is going to happen. The surgery itself for a single level usually takes about an hour or an hour and a half, and then additive time depending on how many levels we're decompressing. We want to make sure that going into surgery that we optimize everything from a medical standpoint to minimize your risk of any type of anesthetic complication and also to minimize bleeding potential. That makes surgery a lot harder if I can't see well. So I always ask that you stop any anti-inflammatory medications like Advil or Aleve or aspirin for at least a week prior to surgery. If you're on blood thinners because of a heart condition or stents or something along those lines, then we'll have to have a more specific discussion and involve your cardiologist in figuring out whether you can be off in order to safely undergo the surgery. So I hope that that answers a lot of the questions about surgery for spinal stenosis, which generally is going to be called, as I said, a decompression or a laminectomy. And I will be having a pre-op visit with you so that anything that comes up from this that wasn't adequately explained, we can talk about again in person. Thank you.